Accessing addiction treatment shouldn't be limited by geography, stigma, or financial constraints. But these barriers still exist, which makes it difficult for many to get the help that they need. How do we dismantle these obstacles? And what role can technology and new models of care play in this transformation? On the show today, Sophie Turner from Talking HealthTech speaks with Pia Clinton-Tarestad from Clean Slate Clinic. And in this episode, we talk about the inception and mission of Clean Slate Clinic in addressing addiction treatment barriers, some innovative virtual care models designed to improve accessibility and outcomes, and the future of healthcare, blending technology with clinical care to pave a new way forward. Collaboration starts with a conversation, Team HealthTech. Let's make it happen.
Welcome to Talking HealthTech, featuring content and community about technology and healthcare. We acknowledge the traditional owners of lands these conversations were recorded and pay respect to elders past and present.
Hello, Pia. Welcome to Talking HealthTech.
Thanks, Sophie. Good to be here.
I know, it feels kind of fun having a little bit of interviewing my other boss.
It's weird, all the connections, but I love it.
Yeah, I know. It's quite fun. Now, I know who you are, but can you do a little bit of an introduction for our audience?
Certainly. So for anyone who hasn't heard of Clean Slate yet, which is always more people than I think, so I'm Pia. I'm the CEO and co-founder of Clean Slate Clinic. A bit about me, I'm a health economist by background. Worked for 13 years in the National Health Service in the UK and still have a UK accent, I think. Then did consulting in the UK and Deloitte in health strategy and system design and commissioning before I started Clean Slate off the back of my lived experience, which I'm sure we'll get into later.
Amazing. Now, Clean Slate, can you tell us a little bit more about what Clean Slate is before we get into like why it started and why it came about, so that we can sort of segue our way into the barriers that individuals face?
Absolutely. And it's only once I started doing podcasts that I realized that Clean Slate Clinic is actually quite a mouthful. So Clean Slate is a social enterprise, and what we do is provide fully virtual care addiction treatment services. So our primary pathway is for individuals with alcohol dependence. It's a 12-month program, and it's a clinically led program. So we take individuals through assessment and preparation. We then do a planned medicated withdrawal with them, and then 12 months of recovery support. And that's all delivered thanks to amazing clinicians and awesome technology through a fully home-based model.
Amazing. So I imagine being a fully home-based model, we can strike that off as one barrier to access taken care of. Can you talk a little bit more to some of those barriers that people experience when accessing addiction services?
Absolutely. And I probably will miss some off the list. So but I'll run through sort of the biggest ones that we see. So as you say, geography is a massive barrier. So the availability of face-to-face or physical services varies hugely across Australia. And it's no surprise that the burdens from alcohol harm are 150% higher in rural and regional Australia. And part of that is lack of available services. So geography, just the distances in Australia. I remember doing a rural and remote strategy in Yorkshire 20 years ago. And it's a joke to me now because nothing's more than an hour away. In Australia, we really have genuine trade-offs between geography and concentration of services and so on. But geography is a massive barrier for many living in rural and regional Australia. Another barrier is financial. So waiting lists for public services are often long and they're overstretched. The Rethink Addiction report that was done a couple of years ago estimated there was a shortfall in treatment places of 500,000 across Australia. So it's difficult to get into the public space, and privates are cost extortionate amounts of money. So you're talking just for the withdrawal component, upwards of $16,000 to go and do that as a private inpatient. And there aren't very many non-inpatient private services available. And rehab, again, some 3-month rehabs might set you back $100,000 if you're going for the really high end, but we're talking tens of thousands of dollars to get private treatment. So financial barriers are huge for people as well. Waiting times, as I mentioned, for public services is another barrier. And that's really important because in addiction, individuals go through these behavior change cycles. I get it. I've been there where one day you're like, I really need to make a change and I'm feeling ready for action and I want to do something. And the next day you're sort of back into cycles, your cycle of drinking or whatever it is that you do. And so you need to catch people when they're ready to change and be available for them quite quickly at that point. So ready to change, I'm going to have a phone call. I'll be booked in for my appointment tomorrow or next week. That works as a model. Saying, okay, great, we'll book you in 2 months' time doesn't really work very effectively. So you lose a lot of people. So that waiting times is a big access issue as well. Stigma is probably the biggest and most challenging barrier that people face. So just shame. A home-based model, I think, is really helpful for that because you don't have to turn up to a clinic. And everybody sort of perceives themselves as different to somebody else struggling with alcohol dependence, somebody else struggling with ice or Coke or cannabis, whatever it might be, because there's this perception that if you're going to a clinic, you're at rock bottom, you're sort of on a park bench somewhere. There's this sort of awful imagery that people have about what it is to be an addict. We don't use that terminology. We don't like it because it sort of doesn't define who you are. So this sort of stigma and shame and fear that if I go somewhere, I'll be perceived as something is a huge barrier to people seeking help as well. And we know that it takes, on average, 18 years for someone with alcohol dependence to actually seek help. And stigma is a huge part of that. So what we cover: geography, stigma, financial, waiting times. The other one is cultural. We get a disproportionate number of LGBTQI plus clients, for example, because we have LGBTQI plus leadership, and Chris is well known for supporting that community. But we know, and from talking to individuals who've been through our service, that already, and it doesn't matter whether you're coming from the LGBTQI plus community, whether English is not your first language, whether you're coming from an Aboriginal and Torres Strait Islander community, these underserved populations are already facing barriers in mainstream healthcare. So they already get care that may be culturally not appropriate. And it's, if you layer on top of that the stigma around alcohol and other drugs and unfair perceptions around association between substance use and particular community groups, for example, it just creates another barrier and another reason to say, I'm not going to go to this service because I'm not going to be treated with respect. I'm not going to be treated without judgment. So I think those communities have an extra layer, an extra barrier that we need to work on. Those are probably the main ones. I don't think I've missed any. Quite a few.
No, there is quite a few. And this is why I love Clean Slate. Having worked in rural and remote regions across Australia, I'm a big one for how do we make services more accessible for people that live in these very vast geographical locations in Australia. And you guys do that amazingly while also breaking down a lot of those other barriers. Can you tell me a little bit about why Clean Slate was started?
Sure. So it's a lucky coming together of the co-founders, I guess. So I've known Dr. Chris Davis for many years. He's a good friend of mine. He's a GP, very passionate about supporting individuals with substance use disorder, and had been doing some sort of innovative primary care-led models when he was GP in the UK, and had brought those over to Australia, and he was running a sort of face-to-face version of Clean Slate, which was GP only. He met Chris Rain, who was the founder of Hello Sunday Morning, which is an alcohol behavior change app. And Chris is a sort of passionate advocate for mental health and substance dependence across Australia. It's what he's been working on for the last 10 years. And the two of them got chatting and were thinking about how do we scale what Chris Davis was doing in his clinic. And Chris tried a whole load of things. Like, he'd spent time with the Agency for Clinical Innovation, he'd spent time with the Royal College of GPs, and actually been part of a huge training program for GPs nationally around alcohol and other drugs. But the take-up in primary care had been really disappointing off the back of those initiatives. And that is, that's largely no fault of GPs. I think there is a stigma issue there. So there is a sort of, even amongst some GPs, a perception that substance use clients are difficult and too time consuming. But there's also primarily structural problems in primary care that create huge disincentives for GPs to take these clients on. There's no Medicare rebate or uplift. So alcohol dependence is more prevalent than diabetes. If you're looking after diabetes clients, you get little incentives within MBS. There's nothing like that for alcohol and other drugs. And the clients are time consuming. And, addiction is not a quick problem to solve. It's not something you can just quickly prescribe for. You need time with clients. And the way that the Medicare billing structure, which is already problematic, is structured, makes it very difficult for GPs to do that and to be fairly recompensed. So understandably, didn't really get anywhere with that. So the two Chris's were sort of grappling with that problem. In the meantime, I'm working as a national lead healthcare partner for Deloitte, and grappling with alcohol dependence myself, which had developed over many years. So I was in this sort of cycle of drinking every single night, staying up late, so using alcohol as a relief from stress, which of course it's not in the long term, but short term, that was the cycle that I was in, knowing that I needed to do something about it. And yet, as someone who had worked in the health system for 20 years, the maturity of my approach was Googling, am I an alcoholic? I can now tell you there's no such thing unless you choose to self-identify in that way. And sort of looking at, okay, could I go to a rehab place? Maybe I could go to somewhere in Bali or somewhere that's far away, because for all the stigma reasons, like I can't possibly go to a clinic in Sydney. But then looking at, there's no way I could go for more than a couple of weeks, because what would I tell my employers or my family? So I was, I think, in probably a very similar situation to everyone else, despite theoretically knowing lots about the healthcare system, having financial resources, being in Sydney where there's plenty of services around. So I was facing those barriers to accessing something. And in the end, I ended up, some small issue at work, and I was like, okay, I'm done. So I quit in anger and burnout and alcohol dependence, and had no plan of what I was going to do next, which ended up being buying a caravan and traveling around Australia. And the day after I quit, I would say Chris knew that I quit, and he'd seen me sort of stressed out and struggling for a while. So he was quite happy that I'd quit. But he didn't waste any time. He rang me the next day. I was like, you've got some time on your hands now, Pia. Why don't you help us get this Clean Slate thing going? So the two Chris's and I got together, and it was our little passion project. I was sort of traveling, making my way around Australia in a caravan, running my own little consulting business at the time. And this was our passion project. At the time, I described it as a very expensive hobby, because we just kept putting our time and money into it because we just wanted to make it work and to do something. We're all very passionate about that. And we did, the stuff that I'd been used to doing in the NHS and at Deloitte. We did service design. We looked at all of the literature. We spoke to Chris's old clients from the face-to-face clinic to work out what is the right virtual care model that could work. Like, how do we build in the appropriate safety protocols? How do we make sure this is clinically effective? How do we take the best from what the evidence tells us we should do and turn that into a comprehensive model of care? And that, for me, by the way, is very different to let's just switch something on to telehealth. This isn't just let's switch a face-to-face consult for a telehealth. It's let's design a virtual care pathway. So that's what we did. We did friends and family testing. So we took 10 friends and family through our MVP, which was some very sort of sketchy, secure, but not very sophisticated technology that we used for our first MVP. Took 10 people through it. I was the 1 in 10, which about correlates with the prevalence statistics, that actually met all the criteria to go through the service proper. So I did my full clinical assessment. Part of that is the alcohol use disorders identification test, the audit. I think I came out at a 26 or a 27, which is sort of bang in the middle of the moderate dependence, very well suited to home-based withdrawal, and I'd never had a history of withdrawal seizure or any of the contraindications. So I actually went through the service proper. So I was client number one who actually experienced the clinical aspects of the service. And obviously we then iterated it since then. But that's how Clean Slate came about, how we developed the model and the origins of how we find ourselves where we are now.
Amazing. Thank you for that. I imagine there would have been a lot of learnings having that experience and building a telehealth model while you travelled around Australia.
Huge. Yeah. I mean, first of all, it proved it was possible. I had a misperception that as soon as you get outside of metro areas of Australia, there's sort of very little internet. Now, of course, if you're travelling the 200 kilometre stretch between the nearest town and Broome, that's actually true. That's where our car broke down. So there are definitely black spots, which can be problematic. But actually, if you're near a pharmacy, which you need to be able to access medications, then you're near good enough internet connection to go through a virtual care model. So even in the most remote areas where, sure, people may have to travel into the nearest small town, this model can still work. So that was a key learning from traveling around Australia, was like, okay, this can work. And, I did my detox halfway between Adelaide and Western Australia, and my recovery support all the way around WA, the Northern Territory, and Queensland. So it proved that the geography barrier could absolutely be broken down. And for me, the stigma barrier as well. I mean, it took me probably nearly 2 years from when we started before I publicly shared that origin story. But still, from a sort of service access point of view, it felt very safe. So it's just my husband knew, my nurse knew, and of course Chris knew, but they'd sort of known anyway, so that was okay. And lots of learning around the technology as well, of course.
Yeah. Before we dive into the technology, I want to have a chat around why the three of you decided to go with a social enterprise over a different structure.
Yeah, we had lots of debates around this. So, we are absolutely sort of social justice oriented group. And it's what I love about us as a group of co-founders, because even if we might have very different views around where to take the organization, priorities, those sorts of things, fundamentally from a values perspective, we're all social justice focused, and that actually makes it very easy to make decisions around what to do next. I think the challenge with that was, again, I'd been in the NHS, I'd also been in the private sector, would say, slightly more values aligned to the public sector. So there's this sort of, I'm not feeling very comfortable about just being a private company, because, and also, perceptions around, there are unfortunately, private companies get a bad rap in the AOD sector. Despite, there are some fantastic ones out there doing great work, but there are also unscrupulous providers preying on vulnerable individuals. So there was a sort of, private doesn't quite feel right for us. We talked about being a not-for-profit. We had quite long debates about this, and Chris Wren wasn't so keen because he'd done it. He'd been there and done it. I do sit on the board of another not-for-profit that has DGR status and so on. And I'd seen the paperwork that's required to prove that you're for DGR status, and the legal costs, which we were totally bootstrapped. So this is going to be potentially unaffordable. And also I started to see, particularly in the AOD sector, this reliance on government funding, and government funding growing ever smaller, or that's what it feels like in the sector. I don't feel like I can set up a agile, innovative, and financially sustainable organisation that is a not-for-profit. And kudos to all the not-for-profits out there that are doing it, because it's really, really hard. So in the end, the social enterprise model felt like, in some ways, sort of on reflection since, I'm like, okay, we've got the worst of both worlds here, because we're sort of not eligible for lots of grant funding, but also the private equity and other sort of private sector funders we're probably too social justice oriented for. So it's sort of, in a way, it's the worst of both worlds. But I actually am still of the view, the idea was, let's get the best of both worlds. So we're a social enterprise. we will be mission oriented, and no one can take that away from us. So we have our mission built into our constitution. So we have we're set up as a standard PTY limited company, but then in our constitution is a set of objects that say, first and foremost, our mission is to tear down barriers to accessing addiction treatment services. And that's where we go. If there's ever any question about what we should be doing, that's the guiding North Star. And that can't be changed without the agreement of all the shareholders. So let's say over time, my shareholding reduces in the company, I will still have significant, and the other Chris's as well, we will still be able to hold true to that mission, or hold, if Clean Slate ever gets taken over, hold the decision makers to account for that mission. So that's why we went down the social enterprise route. It felt like, okay, it's a good social justice fit, but it also gives us a lot of flexibility and a lot of agility to pivot, to look at new revenue streams, to do what we need to do to make sure the organization is financially sustainable. And to be honest, thank God we have, because we have got government funding. We've got some amazing primary health networks that fund us in their regions. But getting government funding is a very, very slow and arduous process. Our fastest growing segment is direct to consumer. So we provide an affordable model direct to consumer, and we allow them to pay us over the 12 months of the program. So we make it very, very affordable and cheaper than drinking for people. And the need is so great out there. We've got people coming to us in droves. And I think had we gone down for the not-for-profit route, that would have all been much harder to establish and taken us too long. So that's why we went social enterprise. And in the end, despite some of the funding challenges we've had, in the sense that, Snow Foundation have been amazing. They don't have restrictions on only granted to DGR status organizations, but lots of foundations of philanthropists do have that restriction. So grant funding has been challenging. Private sector funding has been challenging, but we've got there. And I'm now really, really happy that we've found, I think, absolutely the best of both worlds.
Yeah, amazing. Certainly lots of challenges along the way, but I think that's so encouraging and amazing, like to be so mission driven and to have 3 co-founders that wherever you are at whatever point in Clean Slate's journey, there's that North Star to keep coming back to. And it's such an important aspect for us all.
100%. And it works not just for the co-founders, but for the staff. I think we were at service team meeting yesterday.
I wasn't.
Okay, so a service team meeting yesterday, we did like every 6 weeks or so, we go through one of our values because the team's constantly growing. And we did our staff survey last month, and the clinical team and the operations team love that values aspect as well. Social enterprise is less well understood, but that sort of social justice value set, and we have a sort of written down set of values around inclusion and trust and the things that you expect to see within a social enterprise. It really brings the team together, aligned around that same guiding North Star. So we talk about our mission to tear down barriers to access all the time. There's no one who works in Clean Slate that doesn't know that that's what we're doing. And it really pulls the team behind a common cause as well, which I love.
So I was leaving this question for a little bit, but I wanted to talk to you about what are the major things that are contributing to the success of Clean Slate so far. So can we build on a little bit with the North Star?
Yeah.
What else sort of stands out to you? Because I know you've built a fairly amazing team around you.
I was going to say the people. What is it? People, process, technology. Let's not talk too much about our processes. We've got a bit of maturation to do. But I actually, I'll come back to that because actually from a clinical process point of view, I think we are leading. And if I think about what we do from a clinical governance point of view, I think we're probably, up there, probably better than some of the tertiary hospitals that I've provided consulting support into. But let me talk about people first. So people, we've built an incredible team. I mean, obviously, Sophie, we've got you on it, so we must have done something
well. Absolutely.
And that team has been, and again, great to be a social enterprise because we have flexibility about how we recruit. We're not bound by rules and restrictions. Most of the people that have come to work in Clean Slate Clinic have come to us. So they're people who've heard of the work. So from a clinical side, Chris Davis is so loved in the sector, and so loved by anyone who meets him, to be honest. He's just such a delightful human being. That people flock to him from far and wide and want to work with him. So a lot of our clinical team have come to us either because they know Chris personally, or they've referred clients to him in the past, or because someone working with us has told them how great Clean Slate is. And so we have this sort of constant pipeline of clinicians that are coming to us to say, are there any vacancies at Clean Slate Clinic? I'd love to come and work with you. That's on the clinical side. And I think, that's really down to Chris Davis and just what a lovely human he is. And then on the operations side, I think we're building reputation as a great place to work and a great team to work in, as well as we are, and I use this phraseology reasonably often. I think we're punching above our weight in terms of impact, and we have been since very early on. I mean, we're driving national initiatives with partners in the sector to get digital addiction services on the agenda. We're growing quite fast. So we're sort of building a good reputation, but also, so of the operations, or the management and operations team, 3, including me, now have been through the program. So I wasn't expecting Clean Slate clientele to be our pipeline for employees. But what better place to be, what better place to get them, because the passion for what we're doing. So Chris G, who heads up he's working on our app implementation, is also doing some work around our employee proposition and supporting with onboarding. And clients absolutely love talking to him. He's been through the program, doing amazingly well, and obviously loves what we do. Lee is coming on to support us with our finances. She's also been through the program. It's been life-changing for her, and she really wants to come and help us with our financial management. So having people who've been through the program coming in and bringing that passion is just awesome for us. And that's how we've built the team, and rightly or wrongly, and probably as we get to some sort of size, I'll say wrongly, but at the moment we a bit like the conversation you and I had 6 months ago, we recruit people based on their value set and the skills that they can bring, and then we worry about specifically what role and how can we sort of continuously reorganize and improve the team to bring new people in and create the capacity that we need, rather than saying this is the specific role that we're recruiting to. I mean, we have been very lucky and successful in doing that as well, but in the main, we're recruiting the people on the basis of their values and the skills that they bring, and that's been great for us. On to processes then. I was joking because I know you're helping us with accreditation. There's a bit of work we need to do on some of our processes, but from a clinical process point of view, I think what we've built is really awesome, if I say so myself. Yeah, and then it sounds, we have the luxury, because I have worked in my consulting life with lots of healthcare services that are absolutely passionate about doing the right thing, just like everybody else, but are sort of hamstrung by legacy systems, legacy processes, and making a change is really difficult. So a provider who one of our clinicians works with, who will remain nameless, they had a spelling error on one of their policy documents, and they had to go through 3 committees, and it took 6 months to get the spelling error corrected. And that's just because these sort of, behemoth organizations have been set up based on probably what was best practice process management at the time. They're very difficult to turn in different directions. Starting and designing a service from scratch, and probably that'll be me in 10 years going, oh my God, we're stuck. It's so hard for us to change. But right now, we're able to be agile. We were able to just literally say, okay, what does best look like? Let's build that. We now know that continuity of care is really important. So we designed a service and a workforce model and processes where a client gets the same nurse on day one who's going to be with them through the full 12 months of the program. Those things really matter to people and really make a difference to our success rates. But try implementing that in an organization that's already huge and has rosters established, etc. It's very difficult. So we have been able to design something that I think is optimal or close to optimal. There's always improvement to be done from a process point of view. And then similar sort of story for technology. I watch these huge healthcare organizations that have put in an EMR and are now trying to figure out how to bolt on, CRM systems and e-health interventions and integrate it all. And it's a massive task to be able to design the technology from scratch and say, okay, we know we need proactive pathway management. We know we need multiple comms channels with our clients, so the ability to SMS, to email. We know we need to build all the consent up front to enable us to do those things. So having the knowledge of what good looks like and being able to design that from scratch has been an absolute joy, I have to say. And, I almost feel guilty about it because I know how hard it is for those who've already got legacy systems in. And I know how easy it's been for us to design what we know works from scratch.
Yeah. So if we lean in more to the tech there, what has been the learnings from there? And what's the technology that's really supporting this program?
Yeah. So I think the learnings have been, and my hypothesis going in, I'd say has probably been proven. And I deeply believe this, is that the future of healthcare is the combination of brilliant and motivated clinicians and best-in-class technology. Neither of those things on their own can deliver what we need from healthcare in the next 20 years. It has to be the combination. So whether you're building a piece of health tech for clinicians to use, or whether you're building a new clinical service, we have to have in our mind that we need the best of both. And so I think that was a design principle going in for Clean Slate. So I think that's the first thing to say. If we then look specifically at the technology side, and we have iterated it over time so many times, I think for us as a services provider, with best-in-class technology as a backbone of what we do, then a good enough MVP is a good place to start. So I'm really glad that we were in market and seeing clients within less than a year of coming up with just the idea of Clean Slate, and within 6 months of establishing the entity. And obviously that technology wasn't perfect, but we're learning every day, and I think building a technology stack that you can continuously improve is a key learning as well. So we have swapped in and out modular. So the way our technology works is if you think about a whole load of third-party modules, a key thing for us was building on top of a secure medical records database. We didn't want to take on the responsibility for building an EMR because there are lots of great ones out there. So we did quite a lot of due diligence to look at where do we have that's cloud-based, that has really good APIs that enable us to push and pull data from it securely and is compliant. So that was that's a building block of what we do. But we also knew very early on that it wasn't going to be enough. But we've build and continue to build and iterate what sits on top and around of that medical record system. So CRM, I think we got pretty lucky in what we chose Freshworks as our CRM to sit on top of that medical record system, and that's very flexible and adaptable. I think, if I could go back and spend more time really thinking through the customer life cycles, that's probably a learning. So we've changed them a couple of times, and we're gonna do another round of changes. But we now have 13,000 individuals on that database. So every time we make a change now, it's a big thing. So I think I sort of wish we'd iterated and improved that a bit quicker. But thinking through, certainly if you're a service plus tech, thinking through the life cycle, the journey stages, is critical. So that's a learning. But I'm glad we have the flexibility to be able to make those adjustments. Having an amazing, we're so lucky in that we have Victor. I'm not going to share his surname in case people try and steal him from me.
You'll get poached.
You can't have him, and he won't leave us anyway because he loves what we're doing. But he's so awesome, and so he's got. And we had someone else earlier on who helped us part-time with building the initial code. what Victor has done is really systematize that so that the code that we use a lot of proprietary code to knit these systems together in a safe and secure way and to get maximum utility out of them. He sort of structured that code in a very well organized and repeatable way, and is also he's just got such breadth. So having really good technical skills across, he knows all the languages, Python and Java, and those are the only two that I know the names of, and that's as far as my knowledge goes. He knows all of them, and so can be very flexible in right solution for right coding problem, as well as being really au fait with the systems that we're using and connecting. So having the right technical capability is critical. And then, an important part of what we do is e-health intervention. So we send out drinks diaries, detox diaries, we do outcomes forms. So we gather that data in a structured way. And that enables us to look at our outcomes over time. So we're very data rich. I mean, always more improvement to do. And we're always looking at what next? How can we drive relapse to zero through having insights around who's at risk when along their recovery journey. But we do incredibly well, relatively speaking, in terms of the data that we have around that already. So building structured data as part of your data capture systems and as part of your e-health interventions to give you the insights out the end of it has been key as well. So, I should have said interoperability. It's a design principle for us. All of our systems have to interoperate, and we're very intentionally using a medical record system that is moving towards FHIR standards, etc., so that we can support other parts of the health system as well in terms of uploading to My Health Record, secure messaging between providers, etc. So that's lots of stuff, but those are probably some of the key things from a technology point of view.
Amazing. Thank you. I'm learning so much. If one thing before we sort of start to close our little interview today, what in terms of the data that you have collected, what are some of what's the data around relapse rates within Clean Slate versus inpatient?
Yeah, and I'm so proud of our outcomes, and I truly believe they're world leading. The first thing I would say is it's not a totally fair comparison to compare us between a public inpatient system. Some of the reasons I articulated earlier, by the time you get into the public system, you may have been waiting for some time. You may have come in through the emergency department as an acute admission. And by definition, your chances of success are lower, which is, partly why it's a system we need to redesign and why organizations and clinical approaches like Clean Slate are so important. But the public system does amazing work, and it's not totally comparable. I do think we're reasonably comparable with the private inpatient system. Our inclusion criteria are probably the same. And the typical relapse rate at 3 months in the public system is somewhere around the 50 to 60% mark. The data is not brilliant. There's not loads of research in this area, but we know it's in that sort of area. In the private system, it's probably even higher than that. So let's say 50% upwards. At Clean Slate Clinic, at 3 months, we have 85%, and we only capture data from those that are still in the program. 85% of clients are still in the program at 3 months, and our relapse rate is 5%. So that means a maximum total relapse rate of 20%. But we do know, because we get emails from people and stuff, that some of that 15% that drop off say, I'm doing really well, I just don't feel I need to see my nurse again. So we're somewhere between 5 and 20% if you include all of the loss to follow-up, which is incredible from a relapse rate perspective. And our relapse rate at 1 month, Sydney University evaluated this, is 2%. And again, in the private sector, it's probably somewhere between 30 and 50%. So it's a massive difference in terms of outcome that we're delivering for less money. So we're faster in terms of faster access. We're certainly not faster treatment because we're 12 months, and that's almost unheard of, a 12-month program. We're faster, we're cheaper. So our total program cost is just over $3,500 for the 12 months, compared to an average cost of just inpatient withdrawal of $12,000 in the public sector, $16,000 in the private. So we're faster, we're cheaper, and we're better. So our outcomes data is showing that we're, however you count it, we're significantly better in terms of outcomes. So they say that can't be done, but I think we've done it.
Amazing. So where to next?
World domination, obviously. No, I think
obviously.
There's a few things. Like, I would really like to see us continue to grow and meet the huge need that is out there. And we have plans in place to do that. So we would like to get to a point of that 500,000 shortfall in treatment places. I'd love to get to a point where Clean Slate Clinic gets 10% of that. So we reduce the gap by at least 10% ourselves. Hopefully the rest of the system can pick up the rest as well. And I'd like to do that by disproportionately improving access to those that face higher barriers. So underserved communities, rural and regional Australians. We do pretty well on some of that already. For some, we are reliant on getting more government funding, and that is hard, but we will not give up. So if there's any ministers out there listening who want to help us, call me. So grow, expand impact for underserved communities. And then we'll probably start looking, because this is a global problem. There's more than 160 million people worldwide struggling with substance dependence, many of whom want to access services and can't. So we will probably look to get out to other countries and provide the Clean Slate model in other geographies. And those are the main things for us. So deliver against mission, make a sizable and measurable contribution to reducing barriers to access in Australia, and world domination.
Amazing. And if anyone wants to find out more about Clean Slate, there'll be some information in the show notes. But Pia, thank you for your time today. I really appreciate you sitting down with me in a little different context to how we usually catch up. But it's been wonderful.
I've missed talking about accreditation with you, Sophie, but this has been fun instead. So we can do this sometimes as well. Thanks so much for having me on. It's I love what Talking HealthTech are doing in connecting the community, and I think we have a lot to learn from each other. So it's been great to spend this time with you.
Alrighty, thank you.
We hope you enjoyed this episode of Talking HealthTech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.